Good afternoon, everyone. Coming to you live from Houston, Texas, Methodist Hospital, DeBakey CV Live. This is our monthly chat. This webcast covers atrial fibrillation, specifically issues with AFib and the surgical approach known as the Wolf procedure. This is the webcast in May. In June, July, August, our AV team slows it down a little bit. Our next webcast after this will be in September. However, you can always pose your questions directly to the Facebook site, which is Wolf Procedure, or to the website, which is Wolf Procedure. And that's monitored. So if you have a burning question, then please go to one of those two sites and we're happy to help you out. And lastly, I'll give this phone number out. This is for our AFib Center here at DeBakey Heart and Vascular. 713-441-9342. That's Kimberly's number, 713-441-9342. So in this 3-month interval where we're not on webcast, Facebook site, which is Wolf Procedure, which is monitored by Sandy, who I'm going to introduce in a minute. The Wolf Procedure website, or 713-441-9342. Now, during this webcast, you have two very experienced people. If you have a question, this is a really good time to get your question up. There are two ways to send a question to us, and we will try to get to everybody before the hour's out. If you're on your phone, it's 37607, and then text DeBakey, D-E-B-A-K-E-Y, and text in your message, your question. If you're on a computer, a laptop, go to poll, POLLEV.com, enter DeBakey, and respond to the activity. So you have two ways to call in your questions. We have some questions coming in already, which is good. And again, we'll try to get to all the questions, but don't wait till the end of the hour to send in your question. Better to send it in here at the beginning of the hour. I hear another volume, something going on in the background here. Obed. From time to time, we do a webcast where we just take questions from people that have questions about AFib, you or loved one, someone in your family. And the best person to help with this type of webcast is Sandra Schrameyer. Some of you may already know her. She is the administrator for the Facebook site, and she does a tremendous job, not just with patients who end up having the surgical procedure, the Wolf procedure, but she helps a lot of people who don't have the procedure as well. She's kind of like the mother hen for some of the people that have AFib. She's helped a tremendous number of us around the country and even in other countries, which we'll get to in a minute. For those of you who don't know, she is also a healthcare provider, and she is a registered nurse. She also knows a lot about AFib because she suffered from AFib, and she's had a lot of the procedures that many of you ask about, so she has personal knowledge as well as being a healthcare provider as far as having ablations and cardioversions and the Wolf procedure. So she's very knowledgeable, not only because she's a healthcare provider, but because she's been through this herself. In addition to that, she's responded to patients' inquiries now for several years. So she's seen just about everything. I mean, in healthcare, there's always something else that you've never seen before, but 99% of the issues Sandy's seen. So I'd like to bring her on now to join us and help us with questions. We got some coming in, and I know you have frequently asked questions that we can deal with as well. So Sandy, again, thank you for the incredible amount of time you spend on helping people around the country and around the world. You do your good deed for the day every day. Thanks for joining us again today.
It's good to be here. Thank you.
Where are you right now?
I'm home in Wisconsin.
Wisconsin, okay. Is it warming up yet?
It's about 50 today, so it's getting there.
And as a lot of people know, several people who've had the procedure called the Wolf Pack have gotten together and are taking an Alaskan cruise. And Sandy, you're going to be there as well, correct?
I will be.
I'll join the group on Monday for one day. You're leaving out for Vancouver in just a day or two, right?
Correct. Correct.
And then the cruise goes up through Juneau and I don't know where else. Do you go all the way to Anchorage?
Ketchikan, Skagway, and then back.
Okay, all right.
Juneau, Ketchikan, Skagway.
If you're listening and you're going to be on the cruise, we'll see you, and I'll see you as well, Sandy, but I'll see you on Monday because I'm heading to Juneau on the weekend, and have been very kind to one of our patients has opened up their home. So the Whites have opened up their home, and I'll stay with them and then see you on Monday. Sandy, we got two choices. Maybe the best thing to do is start with answering a few of the questions that are already up. But okay. Before we even start that, I did want to, there is one question that was on the Facebook page, and you answered it very appropriately. But I think it's worth amplifying what's going on. This was a patient who went to Tokyo. According to you, they're not from the U.S., they're from Europe. They had the what's called the WO procedure, which stands for Wolf and Dr. Otsuka. The procedure was done in Tokyo. Everything went well. But the patient is not in rhythm 3 months after the procedure. The patient is distraught and feels like it didn't work and that's it. But I think you and I are here to tell that patient, if she's listening, as well as all the other patients that might have this situation, that that's not the end of the line.
It's not. You know, I think so often I don't paint a rosy picture for anybody. I will tell them exactly, it's not going to be a walk in the park. And I think a lot of people just think that they're going to get off that operating table and they're going to walk home and never have AFib again or flutter. And it's mostly flutter. And I honestly think that that is what she was having, was flutter. The way she explained it to me anyway, it was fast and it was regular. And I tried to tell her that the scars that have been made have to harden to block that impulse, and she'll get there. You just have to give it time and patience.
Now, you had ablations before you had the Wolf procedure, so you know, because you also suffered from some flutter after the procedure.
I did. I had 3 ablations, so I knew I was in for flutter. And I was plagued with flutter. I had an easy recovery except for the flutter. And I kept waiting it out, giving my heart the chance to heal. And the longest episode I had was the last episode I had. Thought I was going to have to see Dr. Fayed for a catheter ablation for flutter, and it just burned itself out, and it has never returned.
Yeah. So here are the things to remember for those of you out there that might be in this boat. Number one, it's not the end of the line. It doesn't mean there was a failure. Number two, are you on an antiarrhythmic? We recommend an antiarrhythmic. I like to use amiodarone at a low dose, and we had a webcast on that with Dr. Fayed. The key is not high dose. If you're not on amiodarone, go on amiodarone. Take 1 pill a day, and after a month, there should be a high enough level. It takes a while because it's a low dose, but it should be a high enough level to undergo a cardioversion. And that may work. And then you can wean off the amiodarone 90 days after the cardioversion. What if it doesn't work? Well, I usually try at least 2 cardioversions. Because sometimes it's the second one that works. What if you go through 2 cardioversions and you're still in flutter all the time? then I think you should see someone like Dr. Fahed. I use Dr. Fahed because he's been in the OR with me. He knows this procedure better than any electrophysiologist in the world. And he's had phenomenal success in patients that have post-procedure flutter. Now, most of them have had ablations, but not all of them. So it's not unusual if you've had previous ablations to suffer from flutter post-op. So antiarrhythmic for at least a month, a cardioversion, that usually takes care of it. If it doesn't, a second cardioversion. If that doesn't take care of it, a follow-up ablation. And that's been extremely successful in our experience, at least here at DeBakey Heart and Vascular and Methodist Hospital. Does that, you agree with that, Sandy? That's pretty much
I
it,
agree,
right?
totally. Dr. Fayed has stellar results.
Mm-hmm.
Stellar.
So, but you have to see this as a little bit of a journey afterwards, particularly.
I try to tell people that, you know, you may be one of that 5 to 7% that's going to need that follow-up catheter ablation. And, you know, nothing's 100%, but this procedure takes it to the finish line.
Well, it's definitely sometimes delayed gratification for some patients, but don't give up.
No.
And as you have said before, there's more than just getting in rhythm. The other half is getting off the blood thinners, and we get almost everybody off the blood thinners immediately. That's goal 1. Sometimes goal 2 takes a little bit longer. I look at it that way.
Huge. That was huge for me because in the back of my mind, I didn't think that you were going to be able to cure AFib for me, but I smiled all the way into surgery, knowing I would never have to take that blood thinner again, and here I am.
Yeah.
So.
And it's been a while since you had your procedure.
It'll be 7 years and 2 months.
7 years and 2 months. Okay. Now let's go take a couple questions. And again, I should repeat this. If you're on a phone and you have a question, there are no stupid questions or bad questions. We take them all. You go 37607 on your phone, text DeBakey, and then text in your message. Or if you're on a computer, you go to pollev.com, enter DeBakey, and then respond to the activity. Okay, I'm now a fan of your YouTube recordings. I have a loop recorder on the left side of my chest and the Inspire hypoglossal nerve stimulator generator on the right side of my chest. Would either of these interfere with your surgical approach? The answer is no. With the Wolf procedure, it doesn't matter if the heart's in rhythm or out of rhythm. We can test and do everything. With a catheter ablation, the heart has to be put out of rhythm with a shock. We don't have to do that. So the answer, as far as I know, is fine. The hypoglossal nerve stimulator shouldn't be any problem at all. Here's another question. I'm almost 73. My atrial flutter and paroxysmal atrial fibrillation started in mid-2020, so we're about 5 years into it. I have been in question chronic persistent AFib continuously since March 24. Okay, so you've been out of rhythm continuously for about a year. I just started the process of booking a case with you, but I'm worried about having additional months in AFib before you can solve this problem for me. How far out is your schedule currently booked? Thank you. Appreciate that, Tyree. First of all, in your situation, we start amiodarone preoperatively. Again, low dose, just 1 pill a day. And in a lot of cases, after about a month or two, the heart goes back in rhythm, which gives you a little more time. It also means you'll probably get a very good result with the procedure. Secondly, even if the heart doesn't go in rhythm, people say that their heart settles down, that the amio or amiodarone settles the heart down. So first of all, you should be put on the amiodarone and give it 4 to 6 weeks. The next thing you can do, and Toshi, Dr. Otsuka does this occasionally as well, is you can have a cardioversion before the procedure. So if you've been on the amiodarone for at least 4 weeks, you can have a cardioversion and get in rhythm if you're concerned about being out of rhythm for a long time. And it is true, the longer you're out of rhythm, the more difficult it is to get back into rhythm. Generally, we're talking about people that are out of rhythm for more than a couple years. You're out of rhythm for a year, so in your situation, I would say 1, get on the amiodarone, 2, get a cardioversion after you've been on the amiodarone for 4 to 6 weeks, and see how that works. At the same time, get on the schedule. The schedule's interesting because we're scheduled out many months in advance. However, we always have openings every month. And Kimberly, the RN who does my work with me, will often say we can't get anybody to come in to get this date. So we have somebody postpone for some reason or another. It can be anything. They're sick or they have to postpone for some reason. And we have 2 weeks to get somebody in that spot. And sometimes we can't get anybody to move up quick enough. So for those of you out there that are on the list and you're far out, if you mention that you can go within 2 weeks notice, say you're retired or you have a job where you can leave with 2 weeks notice, there's a reasonable chance that you'll get moved up on the schedule. So the schedule is a little bit fluid. So that would be my long-winded answer. Does that make sense, Sandy?
Yes, it does.
So let's see. How many more years do you plan on continuing to perform your procedure? Well, that's a loaded question, isn't it? I was going to retire about 5 years ago, but you can see how that worked out. We're trying to get someone to be my understudy here. We don't have anybody yet. We have some younger surgeons who are talented, but they're very busy and they're running around, and nobody's really stepped up to the plate to take over yet. But it's still my goal to do that, to train someone who can do that here and take my place. So in the meantime, I know we're scheduled for at least 9 months, so I think I'll be here for at least 9 months more. Can you compare the Wolf procedure to pulse field ablation now? Yeah, that's a good question. This comes up quite often. I imagine Sandy's heard a lot about this on the Facebook site. Pulse field ablation is a catheter ablation. It's a little bit different energy source. Instead of alternating current, which is what we use when you use the plug in your home, that's what your refrigerator runs on, alternating current. This ablation is done with direct current. So it's very powerful, it's very fast, but it's still an ablation with electricity. The electrophysiologists are quite keen on it because it decreases their operating time. Excuse me, and significantly, it can decrease their time by 50%. They're particularly keen on this since Medicare decreased their reimbursement 20% for catheter ablation because Medicare looked that a lot of people were having repeat ablations and the effectiveness of catheter ablation didn't seem to be that great, so they decreased the reimbursement to try to discourage, I guess, multiple ablations. But because of pulse field ablation, now that electrophysiologists can do it in half the time, they can increase the number of ablations they do per day or per week and make up for that. In addition to pulse field ablation's credit, it's dubbed as being safer. So less chance of putting a hole in the esophagus, less chance of injuring a nerve.
Nerve.
Now I want you to keep that in mind because less chance of injuring a nerve because there's concern about injuring the phrenic nerve than having a paralyzed diaphragm and being short of breath. But if you believe the other path, which is the path that I take, that AFib is caused by a nervous imbalance involving the vagus nerve, and the nerves are epicardial, the key thing that we do with the Wolf procedure is decrease this nerve input to the heart. it doesn't go to zero. There are thousands of these little vagal branches and sympathetic branches on the heart. But we decrease overall the input of the vagus nerve and sympathetic nerve, or the autonomic nerve stimulation to the heart. And that's why we think it works. Now, the nerves on the outside of the heart, not the inside of the heart, electrophysiologists attack this problem from the inside of the heart, which I think is very difficult because there are no nerves there. So if you believe in this new technology called pulse field ablation, or PFA, that touts that it does not injure the nerve, well, to me, that's an issue, because you do have to injure some of the autonomic nerves to get the effect. So there was a lot of excitement about midterm results of the traditional catheter ablation versus radio frequency with pulse field. And I thought that the results wouldn't be any different. And in fact, the midterm results are out. Traditional catheter ablation versus pulse field catheter ablation, there's no significant difference. In other words, the AFib free rate at 1 year was no different in the two groups. But I didn't think it would be. It's faster, it might be safer, but it is not any more effective than radio frequency. They're still attacking the heart from the inside, the nerves are on the outside, and they're not affecting the nerves, which I think you have to do. So it's completely different. Whether you use radio frequency or PFA, is completely different from doing a Wolf procedure or a WO procedure. Producer, I'm seeing Brian Connerly on the screen here. I'm not sure what that is. I'll assume we're still on. We're still on? Yep. Okay. Can someone who had his LAA previous ablated around in a PFA ablation still have it clipped or removed safely and effectively? The answer is yes. Electrophysiologists have noticed that the base or the left atrial appendage can participate in this AFib milieu, and can even maybe be part of the driver of the AFib. So some people will ablate around the base of the left atrial appendage. The problem with that is the left atrial appendage may no longer contract. So then the left atrial appendage is just sitting there. If it's not contracting, you get stasis of blood, or the blood slows down and you can get a blood clot. So most people stopped ablating around the base because they saw there was increase in strokes in patients who had that procedure where the appendage wasn't closed. But as long as there's not a watchman placed or one of the other devices that are placed inside the appendage, then yes, it's quite fine, and I would recommend that the appendage be closed. So it doesn't preclude a Wolf procedure at all. So you probably, are you hearing a lot of chatter around pulse field ablation too, Sandy?
I've had some questions on it, but people generally come to our site for the surgical aspect of treating AFib. But I have had some questions about it.
Well, the midterm results for PFA weren't any better than the traditional catheter ablation results.
The RF ablation, right.
Yeah. But I think it's still going to take over because it's faster, and they perceive it as being safer.
Safer.
Yeah. Here's another question. Had no AFib in 2 years, tolerating antiarrhythmic, channel blockers, anticoagulant. Do you recommend your procedure for me? Okay, so essentially what they're saying is they've been treated medically for AFib, and they're staying in rhythm. Should they have a procedure? How would you answer that, Sandy?
I always say lifestyle helps, but once your heart learns AFib, it doesn't forget. And it will return. It's just a matter of when, but that's my own opinion.
Okay, so some people are on the same line as you, Sandy. That's what's happening. Mr. Producer, what should they do?
Get off of Zoom and go to the Vimeo link.
Okay, so Tyree says, get off the Zoom, because that's just for Sandy.
That's just for Sandy.
That's just for Sandy. That can interfere with what the producers are trying to do here. So Tyree Horn says, get off the Zoom unless your name's Sandy Schrameyer, and go to the Vimeo link, which they should have. Okay, all right. Thank you. Appreciate that. Here's the way I look at it. I look at it this way. Well, you know what comes to mind is a patient who saw me, and he was doing well on medications. And I said, well, you know, it's your choice. And he said, I'm just going to stay on the medications. And then he came back, Sandy, 2 years later. He's got a ball cap on. I think I told you this story before. And
Yeah.
I said, well, what brought you back? He goes, well, I was working on the house up on a ladder, fell off. I was on the blood thinner. I had a bleed in my head, unconscious, went to the hospital, had emergency neurosurgery. They took a piece of bone out of my head and drained the blood. He took off his hat and showed the big incision on his skull, and he said, I don't want to take blood thinners anymore. So that's one issue. Blood thinners are not benign.
No.
And in fact, now, and some people that I've heard talk about this who are quite knowledgeable, that's hematologists, the risk of taking aspirin after 80 is greater than the benefit, because that can also increase your bleeding if you have an issue.
Epigastric and cranial bleeds, absolutely. Yeah.
Yeah, stomach issues, GI bleeding. So that's part of it. The other part is the antiarrhythmics. If they're working, I think that's great. Depending on which one it is, there are side effects, but maybe you're not having any. That's great. But generally, after a period of time, the antiarrhythmics will no longer work properly.
They cease working.
It's almost inevitable. It may not be a year, it may be 4 years, 5 years, but eventually they stop working. It depends on your age. I mean, if you're 85 years old and that's working, okay, maybe you should just leave it be. Although the youngest patient we've operated on in the last 12 months here at DeBakey that I did was 93 years old. So it's not just your chronologic age, it's your physiologic age as well. And he didn't look like a 93-year-old. He didn't look a day over 92. No, I'm just kidding. He looked much younger than 93. So it also depends on what your age. If you're 40 years old and you're on antiarrhythmics and blood thinners, that's probably not a good long-term plan.
The issue with those drugs too is that after a while they lower your pulse rate and your blood pressure so much that they end up having to put a pacemaker in to bring your pulse up to a respectable level so they can increase the meds.
Yeah.
It's insane.
So there are a lot of issues to discuss. My recommendation is if you're in that boat, you're doing well on medical treatment, that's fine, but I think you should explore your other options, talk to an electrophysiologist, talk to a surgeon like me or Dr. Otzika who does this all the time. Look at those options and then do what, just blanked out on his name now, who did the Matrix.
Ross.
Ross Wroblewski's Matrix.
Wroblewski. Right.
Is that still on the Facebook site?
It is. It's in the files.
In the files. So maybe they should go there and look at that. And it has the advantages and disadvantages of each treatment path. I think that could be helpful to this person.
It was very helpful.
Yeah. My blood pressure is usually on the low side with the WP wolf procedure lower it too much? No. What we've noticed is if patients have high blood pressure, there's a reasonable chance that closing the appendage will normalize that pressure to some extent. We have been able to get many patients off their blood pressure medications completely, but not 100%. If you have normal blood pressure, you're fine. You're not going to have to worry about low blood pressure. Does the wolf procedure work on vagal AFib? I get AFib mostly when asleep. Yes, yes, and yes. Because we believe that AFib is promoted, is initiated by the vagus nerve, and you get an imbalance of the vagal nerve, sympathetic nerve stimulation to your heart, and that's what starts the AFib and can sustain the AFib. So, yeah, I believe everybody who has lone AFib has vagal AFib. And also there's some other diseases that I think fall into this category. One is inappropriate sinus tachycardia. We documented the efficacy of the right side of the wolf procedure for inappropriate sinus tachycardia, or IST, in 2007. That's in the Annals of Thoracic Surgery. The first author was one of my fellows at the time, but you can look that up. Another one is POTS, postural orthostatic
Hypertension.
tachycardia syndrome. I think that's all part of the vagal sympathetic innervation of the heart and it being off kilter, and the right side of the mini maze will cure that as well. What other comorbidities could possibly be resolved following this procedure? Well, the most common one that I hear are people that say they've had a lot of problems with their stomach, which could also be vagal related. After the vagus gives off branches to the heart, as we discussed, and Dr. Miranda went over this, the vagus nerve goes to the stomach and gives off branches there, which cause acid secretion. And it used to be 30, 40 years ago, the treatment for excessive acid in the stomach and peptic ulcer disease was to cut those little branches of the vagus nerve to decrease the acid output. But a lot of patients have told me their stomach problems have gone away after they've had the wolf procedure. So that's a big plus. I think also if you're trying to lose weight, it's a lot easier to lose weight if you're in rhythm and you have a little more
energy. Energy.
What? Yeah, you have a little more energy.
And you're not taking those meds.
Oh, you agree with that, don't you?
Absolutely.
Yeah.
Yeah.
If you feel better, it's a lot easier to lose weight. When you feel terrible, it's really hard because you're kind of depressed because you feel bad anyway. So yeah, there's a couple comorbidities. Anything else, Sandy?
Sleep apnea. I
yeah.
think that, sleep apnea I think is huge. They say that studies have shown that it really doesn't matter. I don't think so, because people who have sleep apnea and use their CPAPs, they say it's changed their lives. So losing weight, and especially losing weight, you can probably get rid of sleep apnea altogether.
That's right. They are linked together. And we've had people that have lost up to 100 pounds. And they feel better and they stay in rhythm and they don't have sleep apnea anymore. You're absolutely right. Now, let's go to your list, because you monitor the Facebook site continuously. You've helped so many people. And what should we talk about?
I think we have a lot of athletes, and they're always worried about when they can return to exercise, weight resistance training, and if there's a heart rate they should not exceed, and if so, for how long. Okay.
Let's take the last one first. I recommend that patients, particularly runners, cyclists, try to keep their heart rate below 130 for the first many months after the procedure. Now, if they're staying in rhythm, then at some point we're going to let them go wild. But I think for several months after the procedure, keep it below 130. Particularly if someone was out of rhythm continuously and had decreased ejection fraction due to being out of rhythm and having a high heart rate. You got to give it several months. If they're off the antiarrhythmics, they're staying in rhythm, you can probably push it a little bit more. But really for the first 6 months, in moderation, below 130, please. The first part of that question was, when can you...
Safe to return to exercise, weight resistant exercise.
I recommend that they walk as much as they feel like initially. Lower body is fine. It takes a few weeks for the upper body to heal. So at least for 2 weeks, leave your upper body to rest. Then if you're a golfer, go out and take a low iron, a 9 iron or a wedge. And if you're swinging and it doesn't hurt, then go for it. As far as running, I tell people that you can't just take off running after this procedure because we've decreased the nervous input a little bit. So your heart rate isn't going to go up immediately. It's going to take a little bit longer. So if you're a runner, jog. Jog for a while before you run. If you're a cyclist, take it easy or use an e-bike and then gradually get into it. But you can't just take off in a sprint. Not a good idea. But there are no specific restrictions. I mean, you can't tear anything loose. It's not like that. It's just if you do too much, you'll probably be tired the next day. But I do think keeping an eye on keeping your heart rate at a reasonable level below 130 is a good idea. Do you want to add anything to that?
No, it's fine.
Okay.
Oh, heart rate variability. They always are concerned about the heart rate variability.
Well, decreasing the heart rate variability is actually a goal of the Wolf procedure and the WO procedure, because the whole idea is to not have it bombarded by so much nervous input that it just takes off all the time. So we'd like to see slow and steady. We'd like to see a low heart rate, particularly in athletes, cyclists, runners, swimmers, where your resting heart rate's kind of low, 50s, 60s. If you stimulate yourself, you can get it up to 130, but then it goes back down. So heart rate variability and treatment of AFib don't go together. It's like oil and water. We want to see your heart rate variability decrease.
Okay.
How about another question?
We always talk about the 21-day, 3-week where the heart is most inflamed.
Yeah.
And so I think people on that 21st day just kind of wait for something to happen, and they want to know what they can expect if they are going to expect something at that time.
Okay, well, it's a continuum. It's not an on-off switch. We know that whether you have surgery or you have a cut or you have a fracture of a bone, the peak inflammation is at 21 days. That doesn't mean the inflammation stops at 21 days. That's just the peak. So it's kind of a bell curve. It kind of goes up to 21 days and it slowly comes down. With some people, they have a dramatic response to inflammation. They can have water on their lung. They can have chest pain. That's from pericarditis or irritation of pericardium.
A lot of people complain of left shoulder pain.
Shoulder pain, you'll get the shoulder pain too, that's correct. And that's a sign of a kind of a out of proportion response of your body to a insult. So you really get more inflamed than is good for you. And that's why we use steroids right after the surgery. But for some people, they'll still sort of get this inflammatory response out of proportion at 4 to 6 weeks after the procedure. Generally, if we treat that with another round of steroids, Medrol dose pack, and coltracine, which is an old gout drug, it'll go away. So we use coltracine post-op, but still sometimes about the time people think they should be over the hump, they get this renewed inflammatory response, and we need to knock it down again. So it's a continuum. It's a bell curve. It goes up to at 21 days. It peaks, comes back down, but you still have an inflammatory response for a couple weeks after that 21 days.
Okay.
But I encourage people, if you don't feel right, you should, and you're under our care, send a message to Kimberly through my chart, and we jump on that and give them steroids and colchicine, and Motrin also works. Motrin's very good at decreasing inflammation. So if you take Motrin 3 or 4 times a day for a week, it'll usually knock it down as well.
Mm-hmm.
Yeah, and about 5 to 8% of people will have that sort of over response, so to speak, to inflammation. What else you got, Sandy?
I get a lot of questions about the need for the external pacemaker and the chest tubes. Can you just basically explain why they're needed?
Yeah. Well, the chest tubes are really precautionary. If there is any additional fluid in the chest, we want it to drain, and that's usually in the first 24 hours after the procedure. Your chest cavity, a human chest cavity, turns over about 1 liter of fluid a day. So we're continuously turning over fluid. The chest tubes remove some of that, but they also remove any oozing that's present in the chest. We want to get that out because that's inflammatory too. So that's why we leave chest tubes in. Get the fluid out, decrease the inflammation. The external pacing wire, and I'm probably about the only one in the world that does this, but everybody should do it, is in case, it's particularly in patients who have not been in rhythm for a long time. So they've been on multiple medications, some of these which blunt or slow down your own pacemaker. So when you do finally go back in rhythm with the Wolf procedure, the heart rate might be 40 or 50. And we like to have the heart rate a little bit higher than that right after surgery. So the wire is not attached to the heart. It's inside the heart sac, just sitting there. So if we need it, we can pace the atrium at a higher rate. And we'll do that for a couple of days until the patient's own pacemaker picks up the pace. Why would the patient's own pacemaker increase its heart rate after surgery? Well, because we've stopped the digoxin, that's a poison to the pacemaker. We've decreased the beta blocker like metoprolol, that's a poison to the pacemaker. So you decrease those after surgery, and your own God-given pacemaker will pick up the rate a little bit on its own. But before it does, that wire allows us to run a higher rate for the first couple of days after the procedure.
I know it's normal for the pulse to be slightly higher, as much as 20 points, I think, for a while. And I know that that's a good sign, but can you explain that as well?
Well, the vagus nerve is generally, its job is to decrease the heart rate, and the sympathetic nerve generally is to increase the heart rate. Now on the heart, these nerves are mixed. About 80% of them are mixed. So you can't tease them apart. But a lot of people will get kind of a vagolytic situation where you have less vagus and maybe a little more sympathetic tone, which will give you a higher heart rate. The way to remember it is the vagus nerve is the one that slows everything down. And we usually get more of a vagal effect than sympathetic effect. But not everybody. Some people are the opposite, and they run a low heart rate. And that's okay. What else you got?
Somebody asked a question about the link. Does it record continuously or only if and when an abnormal event occurs?
Okay. So the link which is a implantable loop monitor, which means that it'll record up to 30 days. It'll store up to 30 days of recording. It is looking at the heart, at the EKG continuously, and it has parameters. So if it sees that the heart rate is continuously above a certain number, above 120, it's going to record. And we put in there for how many seconds. So if it's greater than 120 for so many seconds, it records. If it's below 60 for so many seconds, it records. If there's a pause, and a lot of people don't know this, but if you're out of rhythm, if you're in flutter, and suddenly you go into rhythm, it's natural to have a pause. The body,
Compensatory.
it's almost like it's doing its own defibrillation, but you'll just have a pause. Now, if the pause, we can set it so if the pause is, say, longer than 5 seconds, it records. We generally say 5 seconds. If you're not passing out, if you're not getting weak, these pauses are pretty well tolerated. But we do record them. So we set the parameters. Now, it's not recording all the time. It's looking at the rhythm, and if it sees something based on the algorithm that's not normal, then it records.
Okay.
Now, in our own system, we use an outside vendor that looks at all the recordings and then notifies my nurse, Kimberly, if something looks amiss. Mm-hmm. It's not 100% accurate, but it's pretty darn good. It's better than anything else. For example, sometimes the heart can be in flutter, and it's a slow flutter, and the algorithm may not pick it up if it's absolutely a fixed rate. A lot of times flutter will be 120, 140, then back to 100. It's going to pick that up. But if it's an absolutely regular flutter at 100, it might just say it's a tachycardia. So that's where we still need a little human input to determine if it's a flutter or a tachycardia, just a plain old tachycardia. So I think I'm the only one that puts them in. It's extremely beneficial, particularly a lot of these people are on antiarrhythmics. They want to get off antiarrhythmics. Well, if we're looking at the link and we see there's no AFib, we're going to wean the amio. And while we're weaning it, if they stay in rhythm, we'll get them off the amio. They don't have to go in and have an EKG. They don't have to go to the emergency room. Also, the link in particular measures the amount of time that the heart's out of rhythm per month. So it's called the AFib burden. It will tell us what the AFib burden is. We want it to be 0, but it may be less than 1%. Maybe that's okay, particularly in somebody who was out of rhythm all the time before. So we can look at AFib burden monthly. It also tells us PVCs, premature ventricular or atrial contractions, and it tells us percent of time that that's happening per month. These are important parameters in looking at whether or not someone needs treatment for these. Generally, premature ventricular contractions, 1% a month, we're not going to treat that. We're going to let it go. 20% a month, well, that's a different story. That needs to be looked into.
Yeah.
What else you got, Sandy?
I know that lab work can be skewed for quite a while after the procedure, but a lot of people have said that when at home, their EPs want to do an echocardiogram at like 2 months. Isn't that too soon? Shouldn't you wait a year?
I agree with you. It's too soon. For the heart to remodel, particularly if the heart was out of rhythm continuously before the procedure, you really need a year. Right. So we recommend that patients get an echo sometime after 12 months out from the procedure. Let your heart heal. What are you going to do anyway? I mean, generally you're not going to do anything about it. So we like to let it heal for a year have time for maybe the atrium to shrink a little bit while it's being in rhythm. But we're not looking at, I'm not sure why they recommend it so soon, other than the fact that maybe they're reimbursed for doing it, but that shouldn't be a reason to do it.
No, okay. The last one I think is, can the ganglionic plexi grow back?
Say that again?
Can the ganglionic plexi grow back?
Oh,
after
yeah.
ablation?
Can the ganglionic plexi grow back? Yes, they can, but they won't work.
Okay.
So you can see growth of the nerves, but they won't work. And Dr. Miranda made this perfectly clear. He said they may grow back, but they're not going to be functional because the ganglion itself has been interrupted, so it won't work again.
Perfect.
Did we go through your list?
It got that's it. That's what I had.
Okay. Well, on behalf of all the people that are on the website, I want to thank you for all the work that you do. Like I said, you do your good deed for the day every day by helping people that have AFib, helping people that have had the procedure, helping people that haven't had the procedure, but you still help them with advice. And it's invaluable advice from someone who knows about as much of this as anybody in the world, I think.
Well, I feel bad. I mean, I know what it's like to feel hopeless. And I read so many stories and they feel hopeless. And I think, I just need people to know that there's hope.
Yeah. And that's really what people want. I think that's what people want in medicine in general. They want hope. They want some possibility that maybe they can do something to better their situation. And that's why you're there. And gosh, how many people were on the Facebook site when you took it over as administrator?
9.
9 people. And how many are on there now?
About 3,200.
That's a change.
A little bit.
And it keeps growing.
It keeps growing rapidly.
And there's it's a wonderful thing because also people can identify with other people on the on the Facebook site, right?
Well, they do. They all become family, and they will pipe in and they will answer questions, and they will wish people well before the surgery and welcome them after they've had it. So
Mr. Price was on there. I saw him. He's 23 years out now, Sandy. No recurrence AFib. Chuck Miller's about 23 years out now, which is pretty incredible to think about. Chuck Miller was told he might need a heart transplant 23 years ago. Instead, he came to me and said, I think my problem's AFib. He had a very low ejection fraction, it was like 15%, being evaluated for heart transplant. And we did at that time called the mini maze procedure. And he's been in rhythm since, and his heart function improved back to normal. He keeps an ejection fraction of greater than 50%. So the proof's in the pudding with some of these people that have been around a long time. Yeah. Let's see, so we won't be doing the webcast June, July, or August. We'll be back in the saddle in September. There is in the meantime, there is the Stop AFib conference coming up
in August. I'll post that again on the site for people, but I think it's the 8th, August 8th.
Something like that. Yeah, that's Friday, Saturday, Sunday.
Absolutely. Yeah, it's a wealth of knowledge. It really it hits all the buttons, and you can go there and figure out what it is you want to do, and it's just really very helpful.
So that's run by Melanie Truehill. She does a great job. There's a lot. Most of the emphasis is on catheter ablation, and that's okay. But I will be giving a talk, and I don't know if Dr. Damiano is giving a talk. He usually gives a talk, so we get a couple surgical talks. But overall, it's a good thing for people that have this problem, and you don't have to fly to Dallas if you don't want to.
No,
Melanie has an option
virtually.
to do it virtually. which started
Correct.
during the pandemic, but then it has continued after the pandemic. And so I plan on being there. And if nothing else, take a look at, it's under stopafib.org, right?
Correct.
People can get to that site from there and then decide what they want to do.
Exactly.
And I'll be seeing you next Monday, right? In Juneau, Alaska, for the part of the cruise for the Wolf Pack, right?
We will be there.
I guess we have to dress warmly, huh?
Well, I think for the
Not
one
for
tour
you.
that we're going to do. Yeah.
You're from up north anyway. It's the kind of clothes that I need there. I don't even have here in Houston.
You can buy them in Alaska.
I might borrow some from the whites.
There you go.
Thanks again for all you do, for all of you out there.
Absolutely.
Thanks for tuning in. Appreciate your questions. I'm going to look here at the board one more time just to kind of clean things up because we're coming up on the end of the hour, top of the hour. 73 on Entresto, Metoprolol, Xarelto, Digoxin, furosemide. I'm on a lot of drugs. That's okay. We'll get you off most of your drugs if you have the Wolf procedure. If I go, part 2, if I go into amiodarone, would I get off those? I don't know the rest of that, but generally we monitor people pretty closely on the low-dose amiodarone, and then after 6 to 8 weeks, or 4 to 6 weeks, try a cardioversion, might get you back into rhythm. How can you continue care after the Wolf procedure once the patients return to their home state? That's a good question. That does come up a lot. And I continue to monitor the link or the implantable loop monitor. And generally, right afterwards, I don't think patients need any acute follow-up with their home doctors. But after 6 months to a year, you should reestablish care with your family practitioner or internist and cardiologist. If you're staying in rhythm, you probably don't need to see the electrophysiologist. Is that what you're recommending?
Yeah, I don't. I just see my regular doctor now. I haven't done anything else.
Family practitioner, internist, cardiologist if you need it.
Right.
The good news is a lot of times you don't. That's where we'd like to get people. Thanks everybody for tuning in. We'll see you again in September here at DeBakey CV Live. Until then, have a great summer. Sandy, thanks so much for all your help.
Bye, everybody.
So long, everybody.